So our third world leader of the afternoon is not me, it's Brian Stedman, who I have had the privilege of working with for the last 20 years or so. And he is going to talk about the role of interventional radiology treatments in liver-directed therapies in metastatic uveal melanoma, and also look at the influence of them on quality of life. So it's going to be over to you, Brian.
Thanks, Neil. Now, I'm hoping you can hear me. I'm going to
Yep.
start. Well, first of all, congratulate you on cleaning the goldfish bowl. I could see the goldfish there for the first time in a long time. I'm going to talk through interventional radiology and look at what interventional radiology can offer to patients, particularly patients with liver metastatic disease from uveal or ocular melanoma. And a good bit of news for us on the South Coast today. So University Hospital has just been accredited, internationally accredited, as an interventional oncology service. This is a sort of new kite mark you'll see in more and more centres, with a second UK centre. I think Guy's is the only other centre in the UK currently, but you will see more and more interventional oncology services being badged up as being, I suppose, it's a marker of quality. What I wanted to go through is to touch a little bit on the biology and natural history of ocular melanoma, although I'm sure you've heard lots more of that from far more expert opinions than me. Talk a little bit about the literature, the results that are out there for interventional oncology treatments, and also our experience in Southampton, and then think about where our treatments fit into the current treatment algorithms. As you know, cutaneous and ocular melanoma are two vastly different beasts. Cutaneous melanoma, you end up with a tumor. Once the tumor has spread from that primary site, it will normally go to a lymph node, normally a lymph node in the axilla or the groin, depending on where the primary tumor is, before spreading almost anywhere in the body. Ocular melanoma is different. So the globe of the eye has no lymph nodes. So it has none of those lymph node tissue. And it seems that once the tumor spreads from the globe of the eye, it seems to go almost uniquely to the liver in the first instance. And it seems to be the liver which is the driver normally of morbidity, of people getting unwell, and then sadly mortality. And so controlling liver disease is a fairly compelling objective in managing patients with ocular melanoma liver metastatic disease. I'm sure you've seen this many times today. When we're talking about ocular melanoma, you can get disease primarily in the photosensitive bit of the eye, the choroidal bit of the globe, within the ciliary body moving forward, or within the iris. The symptoms are quite vague, and often people present quite late because of that. Treatment of the primary is not controversial. We have a lot of data to tell us what the best treatment is for the primary. Obviously, if the tumor's growing out of the globe, then enucleation, removing the eye, or if there's pain, then removing the eye makes sense. You can have this proton beam therapy. So they put these little markers alongside the primary tumor, and you can then have proton beam treatment, or the iridium plaque. So that's local radiotherapy placed up against the tumor. But the management of the primary isn't controversial, certainly from my understanding. What's important to patients is, having got a primary tumor in the eye, is this going to kill me? And that's what most people want to know. In terms of giving people information, informing patients, then the Liverpool scoring system, prognostication scoring system, seems to be fairly critical. By taking some simple markers, so the size of the tumor, where the tumor is, and then some of the cytogenetics, looking at chromosomal loss and other things, you can then predict the chance this tumor is going to come back. And that's important for two reasons. Number one, I think it's very important for a patient to be well informed about that. That has an implication for them and their plans for life and work and everything else. The other thing it's important for is to decide whether or not patients should be screened. So patients, when they have cancers, when there's a chance the tumor will recur, then often we will screen them, and we're screening them to determine whether or not the disease has spread. In terms of screening, as an imager, as a radiologist, there are three main ways in which we can image patients. So CT is basically X-rays. It's spiral X-rays and then reconstruction to give us these 3D models of patients. The downside of CT is it does involve X-rays, and we try and avoid that as much as we can, especially for screening, because you're talking about having multiple scans over a prolonged period of time, and that dose of X-rays is cumulative in terms of risk of your lifetime. Ultrasound's a very good test if it's done well. It's a bit like, I can't think of a good analogy, but it's you're driver dependent. You need someone that's very good at ultrasound with real attention to detail to get the most benefit from it. So it's not a very robust screening test, because you would end up being screened by multiple different people with different abilities, and therefore the gold standard, certainly from my opinion, would be MR. So MR is using magnetic resonance. So it's using a very high powered magnet. Anyone that's been in one will tell you about the noise when you go in there. You have to wear ear defenders, and you can listen to some music. But this is a MR scan. This is someone with ocular melanoma liver metastatic disease. The melanin actually contains iron. So these are very bright because of the paramagnetic effect on our scan. So this is a scan done without contrast. So they haven't had contrast injected, but you can see how well these tumors are showing up within someone's liver. So when people say, what screening tests should we have? I always think you should cheat, a bit like Lance Armstrong, and cheating is using the best test. So I think the best test is unenhanced liver MR. There's a lot of debate about who should have screening, when they should have screening, and I'm not going to delve into that. Now, what I'm going to give you now is my plumber's guide. I see myself as a plumber. That's what I do in my day job. That's what I'm doing this afternoon. So I either go around blocking vessels when people are bleeding, or blocking vessels to tumors, or unblocking them if they've not got enough blood supply to their legs. But this is an annotation of the liver's been removed here, and you can see the big blood vessel behind. That's the IVC. That's the vein bringing blood back from the legs back up to the heart. This here, the large structure here, is the portal vein, and you see the portal vein is a very big structure relative to this little small red vessel here, which is the hepatic artery. And that's relevant because both of those vessels are taking blood back to the liver, but you can see the dominant blood supply is from the portal vein. And this is it in a different analogy. So hepatic arterial blood flow is about 20% of the blood flow to the liver. 80% of the blood flow to the liver is coming back with, I suppose, what the liver would see as the good stuff. It's basically blood which is rich in nutrients and other things from the gut. They're coming back to the liver to be metabolized, to be processed. So healthy liver likes the portal vein blood supply. The hepatic arterial blood supply is fairly irrelevant to healthy liver. And what we know is tumors, successful tumors, part of being a successful tumor is the ability to build new blood vessels. So tumors are surrounded, or successful tumors are surrounded by a leash of new growing blood vessels. So that ability to grow new blood vessels is a hallmark of successful tumors. And a lot of anti-cancer drugs are targeted at damaging that new arterial plexus. But this is my target. This is the Achilles heel of tumors that allows me to target them. The fact that if we look at normal liver relative to tumors, the density of blood vessels of hepatic arterial blood vessels in tumors is 50 to 200 times as high as in normal liver, means that if I put something into the hepatic artery, particularly if I put beads or radiation particles, they will end up predominantly within tumors and not within healthy liver. And this is an electron microgram showing you just how dense the new blood vessel formation is within a growing tumor. When I go into the liver, I do what we call an angiogram. So I go into the blood vessel of the groin, a bit like anyone that's had a cardiac catheter or cardiac pacemaker. We then come up the big blood vessel, the aorta, and then get into the blood supply of the liver. So this is the blood supply to the liver. We've injected X-ray dye, which appears dark on X-ray images. These are the blood vessels running up into the liver on both sides of the liver. And you can see the tumors light up, from our perspective, like light bulbs, very vascular blush. And that's because of all those blood vessels within those tumors. So this is a pattern of disease I quite like to see. Discrete nodules of tumor. Sometimes we see this pattern where you have diffuse small volume disease. And if you have this pattern of disease, sadly, this is not a healthy pattern in terms of we know patients with this pattern of disease won't treat so well. Now, having got into the liver blood supply, having explained that the Achilles heel of the tumors is the fact they have such a rich arterial blood supply, which allows me to treat them. The next question is, which weapon should I use? What's the best interventional oncology weapon to use? And I'll talk to you briefly about three that different people in the UK or around Europe will have seen or talked about or had access to. The first is this concept of drug-eluting beads, so DEB-TACE, DEB, so D drug E eluting B beads. So this is chemotherapy in bead form, and we implant the beads into tumors and allow the chemotherapy then to leach out. We'll then talk about radiation beads. So Certex is actually a drug name. There's another one, therapies, but these are both forms of radiation bead. And then last of all is this concept of isolating the liver. So chemosaturation or DELCATH, where you isolate the liver from the body, you put a very, very big dose of chemotherapy in, but then you clean the blood out as it's coming out of the liver, so the body isn't exposed systemically to that drug. And we'll talk about the impact these different treatments have on quality of life and show some data. So chemoembolization, this is a blood vessel running into a tumor. Here comes the bead. The bead's big, relatively big in our terms. It blocks the blood vessel. What that does is causes ischemia, so it causes anoxia, kills the tumor partly by depriving it of oxygen, but then the chemotherapy from the bead will leach out. So there's a secondary effect. You're causing ischemia, but also you're causing a chemotherapy effect. The radiation beads are an order of magnitude smaller. So when we talk about radioembolization, actually, it's not a good term. These aren't really embolizing. They're not blocking, but they are delivering a whacking great dose of radiation into the center of the tumor. And that's the effect, or that's the mechanism for why they work. So taste, the first thing, the drug-eluting beads. My analogy would be my old-fashioned bike. I've got a 1950s bike. It's tried and tested. It does what it says on the tin. Nothing fancy about it, but it's reliable and predictable. And I think taste is a bit like that. So to show you an example, these are the beads. So the beads actually start out as blue. We inject doxorubicin or different drugs into them, and they're then taken up by the beads, which swell. This is a catheter inside a liver blood vessel. When we inject the beads, they will preferentially go to where there is high flow. So areas we see as blushing on our angiogram, they will take up those beads, and then they will block the tumor blood vessel and slowly release their drug over 24, 48 hours. Not many patients in the last 5 years have we treated with TACE, but there is one patient here, relatively elderly lady, but living on her own, very fit and well. She wasn't, for lots of reasons, a good candidate for chemosaturation, partly because of her cardiac disease, and she was on blood thinning drugs, had a big tumor at the top of her liver. We treated her initially with radiation. So this is my catheter up into the blood supply, and you can see just how rich this blood supply is within the tumor. So this is the tiny little feeding blood vessel going to it. Then this is the blush of the tumor. We injected radiation. So this is the radiation map. So this is like a heat map for us. This shows me where the radiation has ended up. So the radiation is all within the tumor. She treated very well, but then a year and a half later, the tumor started to come back again. And at that point, it probably wasn't safe to give her radiation treatment again. So we decided to use the chemotherapy beads. And what I can see, although it's obviously what I do all the time, on this image, I can see there's enhancement. So there's blood supply to this tumor. On this image, the blood supply is gone. So the tumor's gone black, and that's because there's no blood vessels left within it. So the tumor's been damaged by ischemia. The thing I would say about the TACE treatment is the treatment works very quickly. It works over about 2 or 3 hours. So patients get quite unwell in terms of they feel quite unwell for up to about 2 or 3 weeks, mostly a flu-like illness, mostly off their food, grumbling temperature. But some people get quite bad pain associated with it. Some people really do become sort of bedbound for up to a week or 10 days afterwards. So it's quite a morbid treatment to have, as well as uh, um, yes, being sometimes a bit more technically challenging. There is some data out there in ocular melanoma. Average survivals quoted between about 6 and 18 months, but they're all small series. In terms of slightly more modern treatment, this is my second favorite bike. This is my De Rosa, an Italian bike. This is climbing up Ventoux. So radiation, when we're talking about SIRT, so selective internal radiation treatment, SIRT. Sirtex is a company that produces SIRT, so that can be a bit confusing. There's another one called therapies, but these are radiation particles. Anyone that's interested in physics or can remember anything from school, these are beta emitters. So these are actually charged electrons. So they have mass. And the reason that's relevant is if I can implant those beads into a tumor, they will cause local damage within the tumor, but very little of that radiation gets out of the patient. So radiation physics is complicated, I know, but some forms of radiation and X-rays that we use for imaging people, as they come towards the body, quite a majority of them will get straight through the body, i.e., they can penetrate quite large or quite deep structures. With a particle like a beta particle, that's not what happens. These get about 2 or 3 millimeters within human tissue. So provided I can get the beads all in the tumor, very little radiation gets out of the patient. The half-life is about 2.5 days, so that means the treatment works over a few half-lives, so it works over about a week, killing the tumor slowly, and that means the patients get less unwell and many fewer side effects from having the treatment. This is a human hair, and these are the particles, so you can see these are small particles. They're not blocking blood vessels, they're just delivering a big dose of radiation. This is what the kit looks like. So this is the radiation vial here. It's within perspex. That perspex is enough to stop me getting a dose because I'm obviously standing here close to a radiation source. We inject it through tubing. So this is the catheter I put up into someone's femoral artery. This is the tubing that connects it. Obviously, I don't want to get too close to the tubing because there will be radiation particles in that tubing. So I either get my fellow who's naive, or I use something long like this syringe opened up to tap the tubing to make sure the particles are all agitated, but you don't want to go near the tubing. Once the dose is inside the liver, i.e. once I've delivered it successfully, the amount of radiation that comes out is very small. So the radiation risk to patients and relatives is very small. The lovely Leslie Kirkpatrick, Dr. Leslie Kirkpatrick, who actually, in terms of Ocumel and the original guidelines, was a dynamo, was our first patient I remember that with ocular melanoma had SIRT treatment. And I remember she wrote in the Daily Mail, and it's quite harrowing to think she felt she was only alive because she knew how the system works and she knew not to accept no as an answer. And I think there was a lot of truth in that. We treated her initially with a right-sided treatment, then a left-sided treatment. That was 2011. 2015, she was running the Milford on Sea 10K with her husband. Sadly, Leslie's since passed away, but she responded very well to SIRT, and we managed her liver disease over a number of years, over 5 or 6 years, and with ablation, radiofrequency ablation. And she only had access to that because of her insight, medical insight, and by pushing, which I think is a, to our discredit as a medical community. There is some data out there. I'm not going to go into it in depth, but what I would say is that SIRT is a good option for patients that aren't fit for liver isolation treatment. There are issues of access to it at the moment, so it's sporadic, patients getting NHS access to it, and it's not a cheap treatment to have done privately. You're talking about 20 to 30,000 pounds for treatment, and the treatment cost is based on the cost of the radiation particles. So this is my beloved Italian bite, a Colnago C60. This is the treatment that I think as the Colnago C60. This is chemosaturation or DELCATH. And the concept of isolating the liver from the body um, is not new. This has been advocated by surgeons, particularly some Scandinavian surgeons, over the last 25 years. And the surgeons showed eloquently that by using surgical clamps, you could put clamps above the vein of the liver, the outflow. You could put clamps below the liver on the IVC. So you could isolate the veins of the liver. And then by putting literally tubing into the vessels of the liver, you could actually inject chemotherapy. And then with a perfusion circuit, they could keep the liver perfused with a high dose of chemotherapy over a period of time while they had the patient on the operating table with their hands inside their tummy. And they showed that they could get good control of liver disease. The problem with that is with all cancer care, when something works, what do we like doing as doctors? We like doing it again. So most oncology treatments, what you want to be able to do is repeat the treatment if the treatment proves efficacious, if it proves effective. And this wasn't, it was so invasive in terms of having such a big operation, it wasn't an option to have this treatment repeated. And as I'll show, uh, the quality of life hit of having a major intervention like this would have been very significant. It would have taken patients weeks, if not months, to get over it. The good news is the system, or the compelling logic for the system, has been then converted into a keyhole type procedure. So what we do now is, rather than opening the patient up, this picture here shows the heart above the diaphragm, and this is the liver here. I can put a catheter up the vein, the IVC, and put a balloon in the right side of the heart and a balloon in the IVC below the hepatic veins. These are the hepatic veins, the veins of the liver, taking blood out of the liver back into the body. So I can isolate the liver using balloons. I can inject chemotherapy using a catheter in the hepatic artery, as I would for CERT or for TACE. And then by sucking the blood that's coming out of the liver and putting it through a heart or a venous bypass circuit, we can then put that blood through a filtering circuit, and that will remove the drug. And that means we can give the patient back their own blood without the chemotherapy. And that allows us to give a very high dose, or if not a fatal dose, of chemotherapy to the liver, but very little chemotherapy gets back into the patient. This is what it looks like in real life. This is the filtering circuit. This is the cardiac bypass pump. And this is the tubing taking the blood, which has been cleaned out, back to the patient. This is us doing our very first case at the time of the London Olympics. So I think 2010 or 2012, that was our first ever case. And we've done over 300 cases now. It does involve a big team, so it's not a small intervention, but it does. We've now got it down to a sort of well-honed pattern. This is what happens. This is the venous catheter coming up, and that's into the right side of the heart. And this here is our arterial catheter into the liver. We then blow the balloon up. This is being blown up inside the heart. We then pull it down, and we see this acorn shape, and that's because it's being constrained at the base of the heart, and so we can see that's then blocking blood from getting up the IVC into the heart. We then blow the bottom balloon up, so that's stopping blood coming up from below the IVC. And then we would inject some X-ray dye. And what this shows us is this is lighting up that segment between the two balloons and also refluxing or going backwards down into the veins of the liver. So that's showing us that we've got good isolation of the liver. We then, once we know we've isolated the liver, we can then put this filtering circuit in. So we do that. And once we've got the filtering circuit in, we're filtering the blood, then we can inject chemotherapy into the liver, and we inject that over about half an hour. So about half an hour of injection of chemotherapy into the liver. We then suck the blood out of the liver and wash it out. That takes about another half an hour. So it's about an hour of intervention. At the end of the procedure, we need to take all these tubes back out again. And one of the things you should be aware of is to be able to get the blood out of a patient and through circuitry, you need to make the blood thin. So we put heparin, which is a blood thinning agent, into a patient at the start of the procedure to make their blood very thin. At the end of the procedure, we need to reverse that. So we have a drug that reverses the blood thinning. Once their blood is sticky again, then we can take these different tubes out. Where's the data? Well, the initial trial, this is about 10, 15 years ago, there was a randomized trial, mostly ocular melanoma, a few cutaneous melanoma patients. The issue with the original trial is that patients who so PHP was the chemosaturation arm, best alternative care was the normal treatment arm. When patients progressed, a lot of patients, over half of them, when they progressed in the control arm, then went on and had the treatment. So that didn't help with our data. But what the original data, even for that long ago, showed is when we look at progression within the liver, there was a big difference between patients on the control arm, best alternative care. So they progress within the liver after a month and a half. Patients in the chemosaturation arm progress in the liver at a much later stage, 8 months. So a very big difference in the time to progression within the liver. So I think this showed that you can control liver disease with this technology. I think there's little doubt about that. What's changed? Well, another cycling analogy, the Sky team. This is Brailsford, this is Chris Froome. The one thing the Sky team have been obsessional about is this idea that every little change, every incremental change adds up. And what they've done is, just moving the bike computer back a few millimeters, new shirts that have a slightly better airflow over them. All these little things seem insignificant, but together they make a difference. So what I would like to just show is the latest data, so the focus study data from the US. It's still not completely mature, but again, a significant difference when we look at progression within the liver, 9 months, whereas 3 months in the best alternative care arm. And a survival benefit, so that in patients in the chemosaturation arm, 19.5 months relative to 14.5 months for best alternative care. So a survival benefit, but even more compelling, a significant difference in liver control. Now, back to the cycle analogy, I think the other thing that needs to be stated is interventional oncology is it's very analogous to surgery, and one of the issues is this is a new technique and it's done differently in different centers. Now, I've seen the focus study data, and the data between different centers is fairly compellingly different. And what I mean by that is this is a technology which is in evolution, and as we get better at it, the first thing we're hoping to see is that we're reducing the complications and making this a much less toxic and complex procedure, and I think I can show you that. But also what we need to then do is, I think we've shown that we can control liver disease. We need to sort of keep on pushing that boundary and see how much more benefit we can get from this technology. This is what happens in Southampton. So patients coming along to our centre will go through our ocular melanoma MDT. So we sit down as a group, surgeons, medical oncologists, interventional oncologists, think who's suitable for this treatment. Patients are then imaged. Obviously, that involves CT of the chest, abdomen, pelvis to make sure there's not disease outside the liver, and then an MR of the liver to see, is the distribution of liver disease, is it something that's amenable to curative treatments or attempted curative treatments like surgery or ablation, or is the pattern of disease such that we need to think about a whole liver therapy? And if we're having a whole liver therapy, is there enough healthy liver to tolerate it? So we like at least half the liver to be healthy, i.e. non-tumor. We then perform the procedure. The patient's the toleration of it's very good. So we treated a guy on, I'm trying to say Tuesday or Wednesday this week. He went home the next day. So patients are now going home the following day after treatment. So within 24 hours, that's a mile away from where we were 5 years ago when we were doing this treatment. What we then do is we do a blood count once a week to make sure there's been no systemic effects. So if some of the chemotherapy leaks out of the circuit, that will have an effect on the bone marrow, as it would with any other chemotherapy. So we check people's blood counts once a week to make sure there's no sign of their counts dipping, particularly their platelet count or their white cell count. We scan them normally at 6 to 8 weeks, and then if we've got good response to the tumours, either tumours are shrinking, then we can repeat the cycles. This is our own data. I'm not going to go into detail of that, but again, we can show that we're improving survival. What's the Holy Grail? Well, I think the Holy Grail for me in terms of interventional oncology is getting some synergy with all the advances that have been made in medical oncology, with all the different new drugs that are coming online. One of the issues I'm sure of Paul or the other medical oncologists talk is being able to hold the liver disease, being able to stop the progression of liver disease, and buying ourselves some time has a real value in this type of tumor. Often, if we can't get rapid control of liver disease, then lots of the other treatments don't become effective or don't have enough time to become effective. I'm sure looking forward, there will be synergy. I'm sure we will see chemosaturation as a mechanism for putting the handbrake on the liver disease, because we can show compellingly that it stops liver disease in its progress and makes liver disease shrink. What it doesn't do is it doesn't deal with extrahepatic disease, so it doesn't deal with disease outside the liver. And much that we can make patients live longer with this treatment, that's not the Holy Grail. The Holy Grail is to get to a place where we're starting to get large portions of our patients living disease-free. And I don't think this technology will get there without the synergy with other treatments. In terms of looking at the morbidity of the treatment, so this treatment's now incredibly well tolerated to where it was 5 years ago. Our latest data we put out to ASCO, what we did is we took, and our fellow that's put this together loves loves annotations. We asked patients day 1 after their treatment, so very early, day of discharge, that's normally day 2 or day 3, 7 days after their treatment, 14 days after their treatment, and 28 days after their treatment, to fill in questionnaires, and they're quite in depth about their physical well-being, their emotional well-being, how well they're functioning, and looking at their social well-being. So quite a comprehensive questionnaire about their quality of life. This took me a bit of time to get my head around this plot. 0 here is baseline. So I'll put a dotted line or dashed line just to remind myself of what that is. Below the line means, in terms of quality of life scores, patients are worse off. And these plots are to do with, they get wider according to the number of patients at that point. And obviously, so on day 1, so immediately following the procedure, most patients' quality of life had dipped. And that's because their physical well-being had been impacted by the treatment. As you'd expect, they're still in hospital. By the day of discharge, day 3, they're still, and if we look at the data, it's mostly due to physical well-being, still feeling a bit under color. But by day 7, they're back to baseline. So by day 7, most patients report that their quality of life and their well-being is back to where they were before they had the treatment. That's pretty rapid. You know, if you look at most other treatments and their side effect profiles, that would be a very good place to be. And I think that's shown. The fact the patient we treated this week wants to go home the day after his treatment. A lot of patients I know will be up to playing golf certainly by day 7, they'll be happy to play golf or play sports, certainly go out shopping. So that's a well-tolerated treatment in terms of the other treatments I deliver. And that's a marker for why patients are happy to come back and have the treatment again. So what do I think this is in terms of the Holy Grail is down to? I think it's down to teamwork. This is Planets, our neuroendocrine cancer charity, but this is showing a whole group of surgeons, doctors, nurses, physios, dietitians, but also patients, lots of patients in there together, all working together collaboratively. That's the joy of Ocular, that's the joy of Planets, the other cancer charity that's dear to me. I think together we can make a massive impact on this. Looking at Leslie's image is quite sad for me, but quite poignant and touching, because it reminds me just how far we've come over the last 10 years. I'm hopeful interventional oncology will have an increasing role in making patients better. So we have these pillars of cancer care. So medical oncology, so that's Paul Nathan et al. Surgical oncology, that's Neil. Radiation oncology doesn't have much in this arena, but then I think interventional oncology has now become the fourth pillar. And I think you'll see this international accreditation becoming more important in terms of finding centres of excellence in the UK, and I'd advocate you look those out. This is how I think you must feel after a day today, absolutely exhausted and overwhelmed. But I'm available. This is my email and Sachin's email, my colleague at the bottom there. Anyone wants to contact us or got any queries specifically about interventional oncology, we'd be delighted to help out. So thank you. I hope that hasn't overwhelmed everyone, but I'm mindful it's Friday afternoon and that's almost the end of the day.
Okay. Thank you, Brian.
Thanks, Neil.
Yeah, always good to hear these things. Again, it's another marker of, as you say, how things have changed in the last 11 and a half years since we first met and for an Ocular conference, and I think we've done one Delcath, and now there's 300, and 300 without a procedure-related death.
And isn't it? And also, Paul, Nathan, all the interventional oncology. It's amazing how the field has changed so drastically.
Yeah. And I think we've really just got to say that this has to continue to give us hope.
Yes.
That whilst there's still plenty we don't know, there is definitely going forward going to be a place for combinations of treatments.
Yeah.
And it can be combinations of medical treatments for some patients, and in others it'll be combinations of medical and IR.
Yeah.
Let's see what I've got. Some questions. Let me just. I'm just going to move something. A little pop-up came in the way. That's trouble with modern technology. Brian, if you're wondering what that is on my head, it's my doctor moved my cursor.
Yeah.
All right, here's a question. I fully understand my metastases are incurable, but I would like to ask, what about those folk following after me? What are the chances they may have something positive to look forward to within perhaps 5 years? So, and that's this question that could be open to you, Brian, or anyone.
Yeah, but I feel the field is even now incredibly more positive than when Leslie was around. Back then there was a real nihilism. There was a real, there were even arguments about whether people should be screened because there was no point in picking up tumors because we had no effective treatment if we did pick up tumors. So many of those arguments have now been compellingly won. And there's so much more engagement and interest from big pharmaceutical companies at running trials. I mean, one of the battles we've always fought is getting funding for all these things, because as a rare tumor group, we have been hamstrung by the level of evidence we need to generate is so difficult to generate, because unlike breast cancer or colon cancer, where pharmaceutical companies are financially driven. These trials are funded by commerce, so they find it hard to convince their investors that they should invest massive amounts of money in doing a trial in what is a fairly niche area. And that means that we are always going to struggle to get that same level of evidence that you would get if you were looking at treatment for breast cancer or for colon cancer. I think we're winning some of those battles, but I suppose in terms of the next 5 years, we just need to, just keep that pressure on, don't we? Keep that pressure on NICE, keep that pressure on the funding bodies to deliver treatments, effective treatments to patients.
Yeah, I think you're right, and I think we'll have to continue piggybacking on other cancers, like we have done with IPI and Nivo and pembrolizumab and so on. They were all introduced for other cancers first, and then it's subsequently that evidence has been generated for the ocular melanoma. And I think that's probably even the case with Delcath. Probably thought of for cutaneous first, and it just surprised everyone that it works so well for uveal melanoma. Okay, I've got another question. So this is somebody who's got lesions in their liver, and they're saying that at what point do the lesions in the liver or lungs, which were considered as benign cysts for a few years, at what point will they turn to tumours and be considered as cancerous?
So I suppose that does fulfill some of my remit as an imager. So if we scan any of us, we're all unique. Everyone is unique. We've all got cysts and nodules and scar tissue in our liver, our lungs, our kidneys. Part of our role as images is to define that these things are benign, i.e., they're of no relevance, or they're important. And there are MR scanning is good for that. There are markers on MR scans of why things are definitely cystic and not tumors. Sometimes we need to do a contrast scan. That's a scan specifically with an injection of contrast as a baseline, as one of the first scans to determine the nature of these things. Because once we know what they are, when we follow someone up, all we're looking for really is there any change? If things stay stable and there's no change, they're very, very, very unlikely to be of any significance. But we normally would expect on imaging to be able to differentiate between things like cysts, birthmarks, scar tissue from tumours.
Yeah, and if something is new,
Yes.
and it wasn't there before,
Yes.
and the fact it's new kind of gives you a clue that that is highly suspicious.
Yeah, and I think that's absolutely.
If you've got somebody who's got lesions that have appeared, and they're being told they're small, less than a centimetre maybe, and they're going to have another scan to wait and see what they are. Is there a cutoff where you say, actually, these have to be something? Is it size-wise?
Yeah, I think if something's truly new, that's worrying, isn't it? It's unusual to develop new. You can, but it's unusual to develop new cysts, new birthmarks, in the in an interval of less than 6 months or a year. So any new lesion would always raise my sort of level of anxiety. And I think on model imaging, on old imaging, we used to have to wait till things were about a centimetre where we could confidently say what they were. On modern MR scans, I think that we have the ability now to detect tumours down to much smaller than that from their signal characteristics.
And from a treatment point of view, they don't treat better if they're bigger or smaller, or what?
Well, I think the danger is if you have limited disease, i.e. you have, a sort of countable number of lesions, as you well know, Neil, I mean, that opens up the prospect of other treatments, which once they become more numerous, come off the table. So the ability to resect, so to cut out tumours, or to ablate, so to sort of damage or thermally damage the liver where the tumours are, those things are only possible when you have a small number of lesions and when they're in the right location. The danger is if you wait too long until they're too widespread, then the treatment planning would change. We're no longer going to attempt to cure someone because we can't. We're then looking at managing and controlling their liver disease with treatments such as chemosaturation, with TACE, with radioembolization.
Okay, thank you for that. Then I've got a couple of questions I'm going to roll together. So it's about funding.
Yeah.
Funding for TACE.
Yes.
Funding for CERT. Funding for DELCATH. Which can you get on the NHS and where?
At the moment, probably none of them. We can get access to TACE just because there is a NHS code for it, and I don't think there's, if I'm honest, too much scrutiny about who the treatments, the specific indication of who it's delivered to. So TACE is on the table in most centres, I would have said. Ablation is on the table in most centres. CERT is currently not available and is not cheap, and that's born of the fact that the dose of radiation is expensive. So we are pushing, but the other side of the coin is we've been pushing for a long time, and so sadly at the moment, CERT and DELCATH don't have funding. And the other problem is now the trial is closed. We were able to recruit patients to the trial. Now the trial is closed. We're not in a very enviable position because we're now in this hinterland where we're waiting for the data to mature, i.e. for the 18-month period after we've closed the trial to get the quality of life and the length of life data to go to the commissioners with, and that won't happen overnight. But of course, that means the company have stopped giving free access to the treatment through the trial. So at the moment, we're in the worst of both worlds.
It feels like the trial stopped over 18 months ago.
Yeah, it does. Yeah.
Yeah. So,
I mean, they have published some of the data, interim data, but they say they're still waiting for that data to mature.
We've just got to keep the pressure on them, haven't we?
Yeah.
Because we won't get anything out of NICE until we've got that.
No, and I sort of understand their reticence. The original trial wasn't published and peer reviewed, which for lots of reasons was a failure of the company. It's not helped patients though, and I do understand NICE's perspective. You can't start taking data that's not been medically peer reviewed. Otherwise, I think you are, the validity of the data is at question, isn't it?
Yeah. Yeah, no, I mean, it is a failing of the company 10, 12 years ago.
Yeah.
Not getting that trial right and
yes,
not publishing it right. So,
yes. No, I agree.
A painful experience that's probably cost a lot of lives, really.
Yes. Yeah.
I've got a comment now, which is from Anna, and one that I absolutely echo. And it's just thank you, Brian, for putting up a picture of Leslie. Leslie Kirkpatrick was somebody that I also was involved with her care. And she was just a force of nature.
Yes, she was.
I've got a feeling she managed about 7, 8 years.
Yes, she did.
I think.
But she managed that by never accepting what she was told.
Yeah.
And at every turn, she was right. Do you know what I mean? She pushed and she pushed and she pushed, and good on her.
And phenomenally knowledgeable, and just a huge presence for us in Ocular UK.
Yes.
Back in the early days, so somebody who really helped us to see
and I don't think
another way.
I'm sure some of your engagement with ocular melanoma was driven by her.
Oh, definitely, no question. Yeah. She helped us to see the injustice.
Yes, yeah, that's right.
I think. Right. I'm going to bring Joe in, but there's also one more comment. This is somebody, Tracy. I've been told I have 2 FNH benign lesions, 2 benign lesions on my liver that they cannot name. I've had contrast MR and PET scan. I had COVID in July this year, had OM for 6 years, 6 monthly scans. The tumours weren't there 6 months ago. Should I be asking for more investigations? I'm happy they've confirmed they're not cancer, but still questioning after living with this disease and battling treatments and radiotherapy damage. Also, I'm an NHS worker.
There is that thing that with liver MR, sometimes you don't see liver lesions until you give contrast. So FNH is basically a normal bit of liver, but it's sort of grown abnormally. So it's a sort of lump of liver, like a nodule of liver, but it's healthy liver tissue. And you wouldn't see that on unenhanced scans. So on the scans we normally do for ocular melanoma, they wouldn't have been noticed. So if they were first noticed when you were given the contrast, that would make sense because they were there before, they just weren't detected before, if that makes sense, because they're healthy liver, so they would look the same to us on an unenhanced scan. So it's always difficult to answer individual questions, but I'm sure if you go back to your radiologist or go back to the centre and ask them, certainly if you've had a contrast MR liver and a PET scan, you've had the right tests. Those are the the gold standard tests in terms of detecting liver disease.
What about COVID? And we've seen people get hepatitis with COVID, and we've seen them get lung nodules with COVID.
Yes.
Have you seen liver nodules with COVID?
No, I've heard more and more people with GI symptoms from COVID, though. People
Yeah.
with sort of, you know,
Yeah.
change in bowel habits, abdominal pain, can be lasting quite a significant length of time. I was unaware of that till a few weeks ago, but that does seem to be a, you know, I think it's like everything, isn't it? It's so rife, COVID. We've all had it, that I suppose it's not surprising that we're just starting to learn the impact it does have.
I would say don't rule out the possibility that that's if it's new, that it might be some COVID inflammatory thing. From my reading, about 2% of people with COVID get a significant rise in their liver enzymes.
Okay, and that's not
So,
we do see that with lots of other viral infections, don't we? With
yeah,
you know,
so it may be, given that it is a disease that gives you nodules,
yes,
certainly in your lungs. And you know, going back a couple of years ago, I saw a few patients who were provisionally diagnosed with lung malignancy, and it was subsequently shown to be COVID.
Okay,
Just post-COVID nodules.
Well, it's given me something to go and look up today.
Yeah, something to look up, but it definitely gives you, a small proportion get a hepatitis.
Yes.
It may be a subclinical hepatitis, as in one that doesn't make you go yellow, but enough to upset your liver enzymes and maybe give you some superficial liver damage. But as you were saying, Brian, if you've got something that wasn't there, it is now there. Get all the reassurance you can, but also I think an early interval scan, like 3 months or something, would that be about right?
Yeah.
There's any ongoing concern, just early interval scan at 3 months rather than 6 or 12. Yeah. I think we're going to wind things up now.